Hi, I'm Joe Graydon.
And I'm Terry Graydon. This podcast of the People's Pharmacy is brought to you by Squatty Potty Toilet Stools. They create healthy toilet posture for fast, easy elimination. Learn more about toilet posture and health at squattypotty.com. That's SQUATTYPOTTY.com.
Antibiotic-resistant bacteria are found in almost all hospitals. Are drug-resistant bugs becoming a public health nightmare? This is the People's Pharmacy with Terry and Joe Graydon.
For decades, antibiotics have been our lifeline against a wide range of bacteria. Infections that used to kill were tamed with modern pharmaceuticals. But increasingly, superbugs have evolved to be resistant to even our most powerful antibiotics.
Doctors and other healthcare workers may be contributing unwittingly to the spread of drug-resistant microbes. Even when physicians and nurses wash their hands, they rarely disinfect their stethoscopes. New evidence says they should.
Coming up on the People's Pharmacy, stethoscopes, superbugs, and robots to prevent infection.
First, this news.
In the People's Pharmacy Health Headlines, scientists have a new scapegoat in the search for the drivers of the obesity epidemic. A study conducted among more than 9,000 Spanish university students for 5 years found a link between eating white bread and the risk of adding extra pounds. 2 servings or more of white bread daily bumped the risk of becoming overweight by 40%. Consuming whole grain breads with meals did not carry the same danger. The problem seems to be that white bread is made with highly refined flour that's lacking in fiber. The carbs in white bread are rapidly absorbed and raise both blood sugar and insulin quickly. The reaction is similar to what happens when a person drinks a sugary soda. This could increase the likelihood of weight gain in vulnerable individuals.
Most women find the hot flashes and night sweats of menopause uncomfortable, but for some women, these symptoms are unbearable. The standard treatment is estrogen replacement therapy, but the increased risk for blood clots, heart attacks, strokes, and breast cancer has limited the use of this treatment. The National Institutes of Health funded a study called Ms. Flash of treatments for the hot flashes and night sweats of menopause. Low-dose estradiol, low-dose venlafaxine, an antidepressant known by the brand name Effexor, and placebo were compared in a randomized controlled trial of more than 300 women. At the start of the study, women experienced an average of about 8 hot flashes daily. Both estradiol and venlafaxine reduced the number by about half, which was more than the reduction among women taking placebo. The investigators concluded that both treatments were better than placebo. This research confirms that antidepressant medications like venlafaxine have a role in treating menopausal symptoms. Another antidepressant, paroxetine, originally sold as Paxil, is now available under the brand name Brisdel to treat moderate to severe hot flashes.
Medicines such as finasteride and dutasteride have been used to ease the symptoms of prostate enlargement. At first, experts believed that these medications might reduce the risk of prostate cancer. A clinical trial suggested, however, that they might simultaneously increase a man's risk of serious prostate cancer. A new study collected data on nearly 40,000 men between 1996 and 2010. Approximately 10% of the men developed prostate cancer during that time. The Harvard researchers found no relationship between the use of either finasteride or dutasteride and high-grade prostate cancer. The men taking such drugs were less likely to develop prostate cancer at all, lowering their risk by approximately 5%. This should make men feel more comfortable about using these medications to help control symptoms of benign prostate enlargement.
Men with metastatic prostate cancer have a new treatment option that's likely to improve survival. Investigators reported on a study of nearly 800 men diagnosed with testosterone-sensitive metastatic prostate cancer. Half were randomized to receive the chemotherapy drug docetaxel, also known as Taxotere. The other half received placebo. All the men in the study received therapy to suppress production of male hormones. Those that also received docetaxel had an overall median survival advantage of more than 13 months. In the world of prostate cancer treatment, this is a substantial improvement. This study produced such promising results that it was stopped prematurely.
Many doctors worry about the negative effects of anti-anxiety drugs such as alprazolam for older people. Getting off such medications can be quite challenging, however. In an innovative study, community pharmacies were randomly assigned to offer their older customers on benzos, usual care, or a patient empowerment initiative. During the study, 2/3 of those who had been offered the empowerment initiative talked with their doctor or pharmacist about how to discontinue the drug. After 6 months, more than 1/4 of these people had successfully withdrawn themselves, compared to just 5% of those in the usual care control group. These results seem to argue for a greater role of pharmacists empowering their older customers for safe medication use. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Most of us take antibiotics for granted. We've become accustomed to the idea that these drugs are magic bullets, keeping us from dying of pneumonia, blood poisoning, or even infected cuts. But bacteria have been evolving for decades, and many are now resistant to antibiotics. Are superbugs threatening to reverse the achievements of modern medicine?
To find out, we turn to Dr. Vance Fowler. He's professor of medicine, molecular genetics, and microbiology in the Department of Medicine, Division of Infectious Diseases at Duke University School of Medicine.
Welcome to the People's Pharmacy, Dr. Fowler.
Oh, thank you. I'm glad to be here.
Dr. Fowler, we had an opportunity recently to see a program on Frontline that was a little on the scary side. It talked about superbugs and dangerous bacteria, but for the most part, the American public, policymakers, and even politicians don't seem terribly concerned about antibiotic resistance. What about you? Are you concerned?
Absolutely. I'm real concerned about the specter of antibacterial resistance.
Tell us why.
Well, it sort of puts us back in a scenario of, realistically having untreatable infections. And that is a scary scenario for clinicians and patients alike.
So are there currently infections that can't be treated with antibiotics?
In a small but growing number of scenarios, the unfortunate answer is yes. And as with most things, it's often even a little more complicated with that. So there are clearly scenarios where you're reaching infections caused by bacteria that are effectively untreatable with currently available antibiotics. More concerning, though, and mainly because it's just a lot more common, is that you have resistant organisms that are treatable, but in many situations the treatment is as bad or worse than the infection. What I mean by that is toxic medications. Specifically, you have resistant organisms that may be impervious to all but just a handful of the most toxic medications we have left in our toolbox of antibiotics. And those are the ones we have to use, like it or not.
Well, Dr. Fowler, I think the American public, for the most part, assumes that there's going to always be something that you'll be able to pull a rabbit out of the hat. And what we're hearing is that there may not be any more rabbits for a while, maybe for a long time. What are the consequences for a clinician who has a really sick patient and no medicine to reverse it? Are we turning the clock back 100 years to, pre-penicillin?
Well, I think there are some real consequences to having rabbits as endangered species, to kind of carry that analogy a little bit, and that's exactly where it's going. When you have infections that are effectively untreatable by the drugs we have at our disposal, or if you have infections that are treatable only by drugs that are likely to cause significant and permanent harm to the patient, in many ways you really are sort of dialing back the time to a pre-antibiotic era. And in fact, I think it's for that very reason that a number of these agencies, Institute of Medicine, World Health Organization, CDC, have underscored the prospect of a post-antibiotic era.
Dr. Fowler, is there anything that people can do to protect themselves and their families from these terrible bacteria?
Yeah, boy, that's a great question. I think there's several things that individuals can do. First and foremost, I'd like to emphasize the importance of hand hygiene. We as practitioners often underscore to patients or mention to patients that it's okay to ask physicians or healthcare providers if they've washed their hands before they began handling the patient. And it that sounds like a really easy thing to do, but I have a personal anecdote on that advice that always resonates with me. That it reminds me that it may be a little harder to do than we would immediately suspect. When I was a long time ago, our oldest daughter is now 14, but when she was born, there was a concern that maybe she had some orthopedic issue. Well, I was an ID fellow at that point. I was full of oats and energy, and we were sitting in the room with my daughter. The orthopedic doctor came in, and here I am. I'm an infectious disease doctor, and I remember he didn't wash his hands. And I thought about saying something, but I never did because I didn't want to be ugly or confrontational. And I've never forgotten that. He didn't wash his hands before he examined my daughter. Now I can tell you, as I've gotten older and more grumbly, I'm less concerned about that now. I will challenge folks anytime about it. But the point is that just that hand hygiene for yourself is adequate, is critically important. Hand hygiene for your healthcare workers can't be assumed. And as difficult as it is to politely ask, have you washed your hands before examining my loved one, as difficult as that is, I think it's probably worth doing.
Well, Dr. Fowler, I really appreciate you describing your experience, because I think that that's how most patients feel. They don't want to antagonize the doctor who is possibly going to do something, important for their loved one's health or their own health. And it seems unfair, actually, that patients should be in charge of making sure that their healthcare providers are washing their hands. But of course, we really want to underscore that as difficult as this is, it's worth doing because it might save somebody's life.
I think so. That's exactly the point I would like for your listeners today to come away with. I personally try in my own practice now, try to learn from that experience, and I try to wash my hands in front of them so that they can see it, and that just sort of lays the whole issue to rest. And but I think that it should be fair game, and it should be encouraged for the loved ones to be able to politely ask that, because it's important. There's some other I think some other things that individuals can do to try to minimize the pressures that are being posed on, that are basically creating these resistant organisms, is limiting unnecessary antibiotic use. For example, I think it's fairly clear that we, as a culture, grossly overuse antibiotics. There's been some approaches that have been described that I think make sense. One of them is this sort of so-called 3-day rule, where you basically, you as a provider would give a patient a prescription for their upper respiratory tract infection, saying, look, if this is almost certainly viral, and if it's viral, it should be getting significantly better in 3 days. So We also recognize you don't want to be coming back into the outpatient facility, wasting another half morning or morning to sitting in a waiting room. So how about this compromise? We'll give you a prescription, but we're going to date it 3 or 4 days from now. And if you're not feeling appreciably better at that point, you go ahead and fill the antibiotic prescription. But if you are feeling, better at that point, then the antibiotics aren't necessary. Trying to find sort of good faith compromises where the important needs of the patient can be recognized, and the equally important needs of the population can also be considered.
Dr. Fowler, looking into the crystal ball, are you hopeful? Are you scared? Are we facing a crisis? I mean, what does the near future hold for antibiotic resistance?
Well, I am concerned about this problem. As I said at the beginning, I don't think this is going to be a scenario that goes away overnight. I don't think this is a scenario that is going to be resolved by any single entity or even a group of entities. And I don't think this is a problem that will dissipate without significant investment of resources, time, financial, intellectual, and other. We didn't get into this problem overnight. It's complex, and it's unlikely to have a single solution. Such complex problems take time.
Dr. Vance Fowler, thank you very much for talking with us on the People's Pharmacy today.
Oh, it was a pleasure. Thank you for the opportunity.
You've been listening to Dr. Vance Fowler, Professor of Medicine, Molecular Genetics, and Microbiology in the Department of Medicine, Division of Infectious Diseases at Duke University School of Medicine.
I really appreciate Dr. Fowler's anecdote about his own experience and his own reluctance to ask the doctor to wash his hands. I think it's really hard for all of us, but it is so very important.
It really is. And we often are somewhat reluctant. We're afraid to antagonize, annoy, or just challenge the doctor or the nurse or any other healthcare provider, but it's really important. Washing hands makes a difference. The other thing is we really do need to invest in new antibiotic development. I think part of the problem has been that the pharmaceutical industry doesn't reap the same profits from antibiotics that you only take for a couple of weeks compared to medications you might take for months or years.
Well, exactly. If you're going to cure something with an antibiotic, it usually is just a couple weeks, and then that's it. Whereas if you have to take something for your blood pressure or your cholesterol, you have to take it every day for years and years.
Yeah, we may have to move beyond the pharmaceutical industry and actually enlist governments around the world in this fight. Well, we need to take a short break. When we come back, we're going to find out whether stethoscopes should be suspected as culprits in carrying germs from one patient to another.
We'll talk with Dr. Didier Pité. He's one of the world's leading infectious disease experts, and we'll talk to him about stethoscope contamination. How dirty are they? Why don't healthcare workers usually think about cleaning them regularly?
We'll also learn about a simple, innovative technology for sterilizing stethoscopes between patients.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339. Online at uttercream.com.
If you'd like to order a CD of this show, you can call 800-732-2334. You can also find it on the website, peoplespharmacy.com.
Has your doctor's stethoscope been cleaned recently? To find out why that might be important, we turn to one of the world's leading experts on patient safety. He recently completed a study on stethoscope contamination.
Professor Didier Pittet is director of the Infection Control Program at the University Hospital of Geneva. He's on the Faculty of Medicine in Geneva, Switzerland. Dr. Pittet directs the World Health Organization Collaborating Center on Patient Safety, and he leads the WHO Global Patient Safety Challenge.
Welcome to the People's Pharmacy, Dr. Pittet.
Thank you.
Dr. Pittet, you have created quite a storm of controversy all around the world with your study that was published in the Mayo Clinic Proceedings regarding stethoscope contamination. Could you please tell us what you did and what you found?
Well, actually, this study is, if you like, the following study of an expertise that we have developed over the past 20 years on contamination of hands of healthcare workers during the practice of patient care. As you know, healthcare worker hands are contaminated by bacteria, and cross-transmission of bacteria from one patient to another is the number one factor of cross-transmission and of healthcare-associated infection. So over the past 20 years, we have been studying the dynamics of colonization of hands with bacteria that healthcare workers would acquire from patients or from the environment nearby the patients. So it was a natural extension to study the dynamics of colonization of stethoscopes, which actually are somewhere the prolongation of hands of healthcare workers, whether they are nurses, physicians, or other healthcare staff using stethoscopes.
What did you do with your study then, and what did you find?
Actually, what we did is we asked physicians to perform a standardized examination of patients who were hospitalized in different wards in our hospitals, in orthopedic, surgery, and in internal medicine. The standardized examination was performed with a stethoscope that was sterile at the beginning, and all over the time of the examination, bacteria, of course, could contaminate the stethoscope, and at the end of the clinical exam, we had the stethoscopes and the hands applied and used a semi-quantitative and quantitative culture technique to reveal the quantity of bacteria that will be on 4 parts of hands and on 2 parts of stethoscope at the end of the clinical exam. So, as you may understand, we look at the 4 parts of the hands that may be important in the cross-transfer of bacteria. And, of course, we also look at the contamination of the stethoscopes, looking at 2 parts of the stethoscope, the membrane of the stethoscope, also called the diaphragm of the stethoscope, which is the part that you use and the part that is applied on the chest or on the abdomen of the patient when you are examining the patient, and the tube of the stethoscope, which is the part that you hold with your hands in order to actually manipulate your stethoscope. So if you like, those parts are very, very close to the fingertips of the hands of the physician during the performance of a clinical exam.
And what did you find?
And actually what we found was that the contamination of the membrane of the stethoscope was very high. The degree of contamination of the membrane of the stethoscope was extremely high. It was as high as the level of contamination of the fingertips of the hands of the physician. So, in other words, there was as many bacteria on the fingertips of the hands than there were on the diaphragm on the stethoscope, as if the stethoscope will be the natural prolongation of the hands, or the hand the natural prolongation of the stethoscope. So a dynamic of contamination of the hand and stethoscope regarding the fingertips of the stethoscope of the hands and the membrane of the stethoscope that was absolutely highly correlated.
Now, Dr. Pittet, I must tell you that this seems totally logical. if you just think about it for a second. I mean, doctors have been using stethoscopes for a very long time. They oftentimes will touch the skin, the chest or the back of a patient, and then they go from patient to patient. And so, what's the big surprise? But I must tell you, in talking with many physicians about whether or not they clean their stethoscopes, the answer has almost universally been no. In fact, we ran into a pediatrician a few years ago. He said, I've never cleaned my stethoscope ever. And this is a doctor who practices at one of the finest hospitals and medical schools in the country. We've seen many physicians who say, well, sometimes I clean my stethoscope once or twice a week. So why is it, do you think, that most healthcare providers have never considered the stethoscope as a possible contamination source?
Probably because the stethoscope has never been subjected to a very close examination, and probably because nobody was aware of the degree of colonization of the stethoscope. I agree with you that there is no surprise with the study in the fact that the stethoscope would be contaminated, but the surprise was that the stethoscope membrane would be as contaminated as the fingertips of the physician performing the exam, which means that if you are asking a physician to clean his or her hands right after a clinical exam in order not to contaminate the next patient that the physician would examine, you should also ask him to clean the stethoscope. It makes sense, because if hand hygiene, which is the primary measure to reduce cross-transmission between patients, is not performed, you will find it absolutely unacceptable. Now, in this case, you can cross-transmit with the membrane of the stethoscope, and in this case, there is no recommendation for the systematic cleansing of stethoscope. The difference with our study is because of the fact that we could demonstrate that the amount of bacteria on the stethoscope was as high as it was on the fingertips, it means that the stethoscope should be decontaminated or cleansed, as well as the hands should be cleaned right before examining the next patient or immediately after for the stethoscope examining the patient.
Dr. Pittet, what is the message for our listeners and for healthcare professionals? What should they be doing going forward?
Well, I think the message is pretty clear. If we are asking healthcare workers to clean their hands before and after patient contact, as well as according to the 5 key moments for hand hygiene, which are actually before aseptic task, after exposure to body fluid, and after contact with the environment, we should also ask physicians and clinicians to actually clean or disinfect their stethoscope after each clinical use.
Dr. Pittet, thank you very much for talking with us on the People's Pharmacy today.
Thank you. It was a pleasure.
You've been listening to Dr. Didier Pittet. He's director of the Infection Control Program at the University Hospital of Geneva. He directs the World Health Organization Collaborating Center on Patient Safety. Dr. Pittet spoke to us from his office in Geneva, Switzerland.
Asking health professionals to clean stethoscopes adds time to busy schedules. Wouldn't it be great if there were an easy way for doctors to disinfect a stethoscope between patients? That's why we're talking with Tuan Dam, CEO and founder of CleanInt Technologies. The company makes devices to disinfect pens, stethoscopes, and remote control devices.
Welcome to the People's Pharmacy, Tuan.
Thank you. Glad to be here.
Tuan, let's start from the very beginning. I mean, you're a software guru. You're the kind of person who's at the cutting edge of technology. How in the world did you ever get interested in preventing infections?
Well, I think the simplest answer would be I saw a need. I was at a restaurant with my son. We were going to pay for our check, and I had to use a pen. And I realized the person in front of me did not wash his hands because he just came out of the bathroom. And so I asked my 12-year-old son, what can we do to prevent this problem from occurring? And gave it some thought and came up with our first product, called the Clean Pen. And from that product, the generations with different ideas led to different products that we created, including the Clean Stylus, the Clean Stethoscope, and our last product, or the newest product, is the Clean Remote UV.
What makes a Clean Pen clean?
Well, the active ingredient that we have used in a Clean Pen, well, let me answer it this way. The sponge that we have that holds the pen, so it's a pen holder, pen sanitizer, the active ingredient is benzalkonium chloride. And as a pen sits in there, it sanitizes or kills the germs on a pen. So when one person uses it, they're going to put the pen back into the Clean Pen, and the person after them uses it, they will not pass the germs from one person to the next. And that's safe, it's harmless, and it's convenient. It's a very attractive product, and we've received a lot of compliments on how it looks and how accommodating it is.
Well, we got interested because of Clean Stethoscope, in large measure because we hear from infectious disease experts all over the country that the most important thing that health professionals can do is wash their hands. And so there are all of these campaigns to get doctors and nurses and everybody in between to wash their hands between patients. And patients are now even being encouraged to ask their health professionals to wash your hands or have you washed your hands. And yet there are, the vast majority of hospitals that have absolutely no policy when it comes to stethoscopes. And so a doctor or a nurse goes from patient to patient to patient using the stethoscope that never gets cleaned. Tell us about Clean Stethoscope.
Well, Clean Stethoscope is a product that we created when we had an EMS director come to us and when we were presenting the Clean Pen. And Joe, he said the exact same thing you just shared with us. He said the pen is an instrument, but I have to tell you, nobody washes or cleans a stethoscope. And he asked us, can we create a solution for that? And we came up with an idea for the Clean Stethoscope. And the way it works is, imagine if it's a name badge with a magnetic clip. You would attach it to your uniform or scrub. The diaphragm of the stethoscope would simply rest in the Clean Stethoscope holder. And as it sits in there, again, the same active ingredient and the same sponge technology would clean the diaphragm so that when they're ready to use it, they simply pull it out and use it as they normally would. And they're going to prevent the cross-contamination and, again, prevention of infections from one patient to the next. What we've also been told, because of the device, is when the physician or nurse or the healthcare professional wear our product, it takes the weight off of their neck, so they really don't feel like they're wearing their stethoscope around their shoulders or their necks.
Now, Tuan, why is all this important? I mean, why should we care about the pens that we use at the restaurant or the stylus that we use at the bank or the stethoscope that our nurse uses when she listens to our heart or when our doctor checks our lungs? I mean, what's the deal with germs these days?
Well, to be honest with you, when I first got into this industry, I did not realize how bad infections were. And when we look at the reports from CDC, when they tell us, and this is an outdated report, but I think the data is relevant to the current time that we're talking about now, 99,000 deaths occur because of healthcare-acquired infection. And when you think about that, an infection causes such a prolonged care. It's not just you go get the pill, you go home and you're fine. An infection causes a very, very long, painful, agonizing treatment. And a lot of times it is life-threatening. And so if we can prevent that with simple, just things that will, as you said, wash your hands, clean your instruments, if we can prevent one or two of those, then we really have done something to improve, I believe, society and helping people stay healthy.
All right, now we're going to ask you about something else. In a hospital room, there is usually a television set, and that television set is operated, as most TV sets are these days, by remote control. Remote controls are awfully hard to clean. Do you have any way of helping with that problem?
We do. In fact, we have a new product called the Clean Remote UV, and the way it works is it's a canister, if you can imagine it. It's a very elegant product, and as you look in or walk in to your room, you'll have the remote control sitting in the Clean Remote UV. When you pull it out, you use it as you normally would. Doesn't change how you operate. When you're done, or when you want to put it down, or when it needs to be cleaned, you simply put it back into the Clean Remote UV. It knows the product is back in there, or the device is in there. It rotates around, and within a minute, the UV light stays on, and it kills the germs, and it is sanitized.
So that's using a completely different disinfectant process.
It is. It's ultraviolet light, which is very safe and has been found to be very effective in getting rid of germs, bacteria, and anything that can cause harm from one person to the next.
Now, when I think of remotes, I mean, yeah, hospitals would be an example of where there could easily be a problem because the house cleaning staff would have a difficult time cleaning them. But then I think about hotels, and I think about, the studies that have been done suggesting that remotes are really grubby and grimy and coated with some pretty nasty stuff.
It is. Something new that we researched, and when we started finding out how dirty remotes were, we were shocked. Something called the ATP test. It's a swab that you can take a Q-tip type, and it's this test that they do in housekeeping, in sanitization, hospitality, and they swab different instruments. And when we were doing that, we found out that the remote controls came in at readings of 3,000 or 4,000, what we call relative light units, or RLUs. In fact, one study that just came out showed a remote control having 22,000 RLUs. And you can imagine a safe number is in the 35s to 70s.
So
this remote control came in at 22,000.
Well, what does that mean, Tuan?
That means the number of bacteria, harmful organisms that are on the remote, when that number is that high, the chance of you picking up something that someone else has transferred to the remote control before they wash their hands or before they use the remote, they're transferring that. They're leaving that to the next guest or the next patient to pick up and share. And some things are not worth sharing. Some things are just things you don't want to share with somebody else.
Tuan Dam, thanks very much for talking with us on the People's Pharmacy today.
Thank you so much for having me.
Tuan Dam is CEO of Clean Technologies, a company that makes devices to disinfect pens, stethoscopes, and remote controls.
Coming up, we'll talk about new ways to clean hospital rooms. Could a robot help?
You're listening to the People's Pharmacy with Joe and Terry Graydon.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Squatty Potty Toilet Stools, creating healthy toilet posture for fast, easy elimination. More information about how toilet posture affects your health at squattypotty.com.
And by Red X Industries, makers of utterly smooth foot cream with shea butter, helping dry, cracked feet feel soft and smooth. The number's 800-345-7339, online at uttercream.com.
If you'd like to order a CD of today's show or any other People's Pharmacy broadcast, the number to call is 800-732-2334. Today's show is number 948, or you can find the show online at peoplespharmacy.com.
Today we're talking about the spread of superbugs and how to reduce the risks. Hospital-acquired infections kill over 100,000 people each year. That doesn't count infections people pick up in ambulatory surgical centers or nursing homes. Because hospitals are not required to report antibiotic-resistant outbreaks, it's hard to track the spread of superbugs.
Even if doctors, nurses, and other healthcare workers are conscientious about washing their hands and cleaning their stethoscopes, there's still the problem of bacterial contamination of hospital rooms. Cleaning the bed, bathroom, door handles, light switches, and other hard-to-reach surfaces is an ongoing challenge.
To learn about a high-tech solution to this complicated problem, we turn to Mario Suarez. He's the director of the Environmental Health and Safety Department and the Infection Prevention and Control Department at the Methodist Hospital System in Houston.
Welcome to the People's Pharmacy, Mario.
My pleasure. Thank you for having me.
Mario, you have one of the most difficult jobs in the hospital. We are told these days that hospital-acquired infections kill at the very least 100,000 people each year. Getting rid of those bugs is a challenge. That's your responsibility. What's it like?
It is a very daunting responsibility, to be honest with you, and ultimately it is everyone's responsibility. We try to combat it through policies, procedures, hygiene practices, and of course the implementations of novel technologies such as our UV-generating bug zapping robot that we currently have right now.
We'll talk about that in a moment, but first, how serious is this problem of hospital-acquired infections in your institution? I mean, how vigilant have you had to be over the years?
Oh, we've had to be very vigilant over the years, and even more so these days because it would actually impact our performance from a Medicaid and Medicare standpoint also. So not only from a patient-centric standpoint with regards to making sure that our patients have not only the best experience within our hospitals and the safest experience that thereof, but also in supporting, maintaining, and sustaining the hospital's daily functions.
So when you say it would have an impact on Medicare and Medicaid, what you're saying is, explain it a little bit, please, if you wouldn't mind, Mario.
Okay, so recently, as you all probably are aware, the Healthcare Reform Act that was passed dictates that hospitals will no longer be reimbursed for hospital-acquired conditions. Healthcare-acquired infections or hospital-acquired infections are one of those conditions that the federal government would no longer reimburse hospitals for. Keep in mind that whenever a patient acquires a hospital-acquired infection, their length of stays within the hospital actually increases. Thus, the amount of revenue resources that are required to contain, suppress, and eliminate that infection actually are costs that will be absorbed by the hospital too.
And how expensive is that? I mean, aside from the incredible suffering that a patient may undergo.
Well, there's, of course, the mental and physical anguish of the customers, which is one of the biggest things that we worry about. But from a cost standpoint, you're talking on average, say, for example, a central line bloodstream infection. The CDC is reporting actually costs about $20,000 per infection.
So that's a lot of hit to your bottom line.
Definitely right there. And of course, it continues to climb depending upon the type of infection. Surgical site infections, for example, are another type of infection that actually costs the hospital even more money, astronomically amounts of money, and ultimately can actually lead to the death of the patient overall if not captured and treated appropriately.
We hear a lot these days about something called C. diff and something else called MRSA, methicillin-resistant Staph aureus.
That is correct. And C. diff, your C. difficile or Clostridium difficile organisms, both of which are actually very hardy organisms within the hospital. MRSA being very hardy because it is methicillin-resistant, which means that it's a drug-resistant organism, and there are only a very narrow spectrum of drugs out there that can actually treat that particular infection if you do acquire it. With regards to C. diff is more of a spore former, and being a spore former, it's a little bit harder in the environment to actually eliminate as a result of through disinfectants and through sterilization processes.
So what are the usual approaches that a hospital like yours would take to make sure that organisms don't get passed from one patient to another?
And in particular, we're interested in, the hard-to-get-to places, like bed rails and bathrooms, even the remote control for the television set. They may be hard to clean.
They're very hard to clean, and not only that, they're high-touch areas, not only bed rails and bathrooms, but also doorknobs being also a big contributor to the spread of organisms within hospitals. Traditionally, what many hospitals, including ours, does is that we implement infection control practices revolving around isolation. So we isolate those patients and implement protocols of certain procedures that need to be conducted and, of course, certain processes that need to be conducted, whether that be wearing the appropriate personal protective equipment, gowning, gloving before you enter, and also doffing and getting rid of those gowns before you exit the room to minimize transition or at least transmission to other areas of the hospital, combined with unique decontamination processes will actually curb the spread of those infections.
Now, for some cleaning person who may be paid, a little bit better than minimum wage to go in and get down on hands and knees and get every single spot in the room. I mean, it seems almost impossible.
It is practically almost impossible, and it's actually very challenging. And not only that, it is also impacted by the time that is required to turn the rooms over for other patients that are waiting. So, and that's why we've leaned towards some technologies that are out there, in fact, leading towards the 3D technology that we're currently spearheading and utilizing within our hospital. It is supposedly used, or at least it's supposed to be used, to bolster the cleaning processes of those housekeepers that are under the time crunch to resolve or turn the room over for the upcoming and waiting patient.
All right, so tell us about this robot.
So I'm sure that many of you have watched Star Wars in the past also. There's a cute little robot in Star Wars called
R2-D2.
Correct. And if you can visualize that is what this robot looks like. It's a cylindrical-based robot with a dome-shaped head.
Okay.
It is actually embedded with multiple UV light bulbs, and it has a few little knickknacks associated with it to lend to exposure times, controls, and of course making sure that it can be functioned safely. But basically this robot emits germicidal UV light or UVC light into the room to sterilize those hard-to-reach areas, in addition to the high-touch areas in the room, including the remote controls, bed rails, and the bathrooms for that matter also.
Now, I understand. You said something about UVC. What is UVC?
Okay, so UVC is basically a short-wave spectrum radiation that is actually in the spectrum of light itself. It is a subset of ultraviolet radiation that's emitted by light or by the sun overall. It can be artificially, of course, harnessed through light bulbs. There are three various different bands, UVA, UVB, and UVC. Typically, UVC is the most effective at disrupting cell membranes and DNA within cellular structures.
How long does it take?
It depends. And so, for example, you mentioned two very interesting bugs earlier on, MRSA, your methicillin-resistant Staph aureus, and your C. diff. For example, your MRSAs or your typical bugs can be neutralized within a matter of minutes. So you're talking 20 minutes to clean the room overall, whereas your C. diff may require up to 50 minutes of exposure to the UV light because of its hardiness and resistance to the ultraviolet radiation.
Mario, we've been talking about bacteria, and they can be hard, as you pointed out, C. diff in particular. But what about viruses? We have a dear friend who is currently being treated at one of the major medical centers in this country for multiple myeloma, so his immune system has been suppressed. He was getting ready to be discharged from the hospital, and he came down with influenza. He was in terrible shape, and it turns out 30 other people on the floor were also infected by this influenza bug. Some of them were hospitalized for a very long time as a result. So can this machine, this robot, kill viruses as well as bacteria?
Definitely, and actually your viruses are less hardy than many of the bacteria that are out there, so it will be very effective against multiple viruses with a shorter contact time associated with that.
So, Mario, why don't all hospitals in this country use this kind of technology? I mean, it sounds like it is the natural evolution. You're in charge of infection control. It sounds like this is working for you.
And to be honest with you, I think it's the technology, at least the utility of the technology in this manner, is new to this industry. Ultraviolet radiation for the control of microorganisms has been around for many years, many decades, to be honest with you. It is now being introduced into the healthcare setting with regards to the neutralization and sterilization or decontamination of hospital rooms as of late. But it is a new technology to the healthcare setting with regards to actually decontaminating hospital bedrooms. So my guess is that it will gather more pace as more data becomes available, and of course, it becomes more readily available to the general public. Right now, it's a little bit costly on the front end to purchase it, but to be honest with you, with the cost of hospital-acquired infections and the cost of it actually rising throughout the hospital industry, I think that this will be something that many people would actually lean towards to create a safer environment for not only their patients, but also for their bottom line.
Now, you said a little bit expensive. Just how much does one of these robots cost?
On average, about $100,000.
So That's a pretty big bill.
It's a pretty big bill, but think of it in mind or in light of hospital-acquired infections. If the average hospital-acquired infection costs $20,000 per patient per infection, this thing will pay for itself hand over fist in a matter of months, especially if you're reducing the amount of infections. Not only that, the quality of care and the experience of the patient overall.
Now, Houston Methodist Hospital has one of these robots, and I imagine you've got it going all day long in different rooms?
We have it going all day long in different rooms, and we also utilize it at night during our ORs also. So while our ORs are down during the night periods, we actually use it to clean our ORs to ensure a sterile environment for our surgery staff and for patients that will be entering there the following morning.
So all the operating rooms then get disinfected with ultraviolet light at night?
Many of them do. We try to go through a cycle of it. We have quite a few operating rooms that we're working through right now. And at the Houston Methodist, we're slowly trying to acquire additional models of this unit so that we can actually optimize its use and, of course, its performance throughout the hospital.
Mario, do we have any data to suggest that the robot is making a difference when it comes to reducing hospital-acquired infections?
Currently, right now, we've started utilizing it, I think it's approximately 6 months now. So the data is still very lagging with regards to hospital-acquired infections. But what we've done is that we've done countless studies in multiple units, both in patient care units, intensive care units, and also in the ORs, that actually shows that there's a significant reduction in microbial burden within these areas with before and after the use of this UV light robot.
So you've done studies that would, for example, send a microbiologist in with a swab to find out if they can grow anything off the surfaces.
Exactly. So traditionally the study design is housekeeping will enter into a room or facility, conduct their usual terminal cleaning of the facility. Once the patient actually leaves or is discharged, we grab a sample, plate it out. We then introduce the UV light robot into the facility also, and then do another sampling event afterwards. And in many instances, we'll actually find what we're calling coag-negative Staph aureus colonies, which is basically skin flora that may be left behind due to either incomplete cleaning or ineffective cleaning associated with the detergent that they're using or disinfectant that they're using. But once the UV light robot has been introduced into the environment, everything is wiped clean. We find no cultures that grow thereafter.
Mario, what's the take-home message for our listeners? Should patients start asking hospitals to have better infection control by using robots?
That is one of the things. And to be quite honest with you, what Houston Methodist is actually experiencing with our patient population and with our community out there is we have very well-educated patients. They know our infection rates because it's actually published both at the local level and, of course, at the national level. And also that they're actually very, very knowledgeable and actually inquiring about the utility of how we're trying to curb and control infections within the environment, because no one wants an infection, to be honest with you.
No one does. I have one last question I have to ask Mario.
Yes.
I know that the robot is made by a Texas company. Is there any financial link between Houston Methodist Hospital and the robot maker?
None whatsoever. In fact, what we're doing right now is we're meeting with leadership within Houston Methodist to actually evaluate other models and other brands that actually provide similar UV technologies to try and improve our efficiencies, and also trying to figure out which one best fits our modeling, our organizational modeling, and of course our staff modeling within the institution. So we're still trying to tweak our process to improve our efficacy and our efficiency with delivering the safest environment to our patients.
So, bottom line, Mario Suarez, what would you recommend to other directors of environmental health and infection prevention and control in hospitals around the country?
To actually give it a chance, I would actually recommend that they review the information, review the literature, take a few demos of it, and see if it's something that fits their mold and actually their organization. I think many of the organizations, especially healthcare hospitals that are working with patients that have a high acuity and or patients that go through a lot of surgeries, or immunocompromised patients for that matter, could significantly benefit from the utility of this piece of equipment.
Mario Suarez, thank you very much for talking with us on the People's Pharmacy today.
No, thank you all. My pleasure.
You've been listening to Mario Suarez. He's the director of the Environmental Health and Safety Department and the Infection Prevention and Control Department at the Methodist Hospital System in Houston.
We spoke earlier with Tuan Dam, founder and CEO of Cleanint Technologies.
You also heard our interview with Professor Didier Patet. He's the director of the Infection Control Program at the University Hospital of Geneva. Dr. Patet also directs the World Health Organization Collaborating Center on Patient Safety.
The hour began with Dr. Vance Fowler, professor of medicine, molecular genetics, and microbiology in the Division of Infectious Diseases at Duke University Medical School.
Lynn Siegel produced today's show. Al Wodarski engineers the program. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible in part by Squatty Potty toilet stools, creating healthy toilet posture for fast, easy elimination. More information about how toilet posture affects your health at squattypotty.com.
And by Red X Industries, makers of Utterly Smooth Extra Care 20 Cream with 20% urea for extra skin protection. 800-345-7339. Online at uttercream.com.
If you'd like to order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 948. That number again, 800-732-2334, or find it at our website, peoplespharmacy.com.
When you visit our site, you can check out prescription drugs, herbal medicines, and home remedies. You can share your own experience and comment on today's show.
You could also sign up for our free online newsletter or the free podcast of the show. You need never miss another People's Pharmacy program again. You can also share it with a friend. You'll find it all at peoplespharmacy.com.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks for listening, and please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to the People's Pharmacy.